We're very excited to have the second annual Global Health Economics Colloquium, and particularly pleased that today it is not just a UCSF affair, but co-sponsored by our friends at Stanford and at UC Berkeley.
We have a really engaging panel this morning, and I wanted to start out with a quick background. When I was a resident in my final year of residency applying for cardiology fellowships, I told my cardiology mentor that I was going to take a year off to go to grad school to study health economics. And she and I had worked together for a couple of years, and she looked me straight in the eye and said, "Kazi, get serious now. At some point you have to get a real job." The one good thing that has come out of this toxic debate around healthcare reform is that both sides of the spectrum at least agree on the fact that costs are a problem here in the United States. In other countries where resources are far more sparse, the recognition that considering costs is not just important, it's the only way forward, has long been present. Europe and Australia and our northern neighbor have incorporated costs into their regulatory processes or in their purchasing processes, and now increasingly low and middle income countries are interested in understanding what their money is buying when they invest in healthcare. We've seen an explosion in cost effectiveness papers in the literature, and you would think that because there's so much interest, the methods around costing have been figured out already. What we'll see in this morning's panel is that that's not exactly the case. We're still trying to understand the best ways to capture costs, to measure cost effectiveness.
So one thing I would like to emphasize is that what I think we're interested in is to look at efficient purchase of non-health outcomes, equity, and then interestingly, financial risk protection. So when you think about the cube, and I think in this afternoon we'll talk more about this, is how one can move efficiently on the cube. So I'm buying, health gains, in a cost-effective manner, but I can buy in a cost-effective manner financial risk protection. So that's one outcome that we're very interested in, is to have, how much it costs per poverty case averted.
I was just at a meeting last week where Kenyan Ministry of Health, woman working on their Kenyan strategic plan for HIV/AIDS says we don't even have some costs for interventions that we want to scale up, and yet they have to estimate their next 5-year national strategy.
And with large reductions in the cost of drugs, we can think about having a global program to actually eliminate hepatitis C. Access is very important. By no means do I want to convey the idea that cost effectiveness is the only thing that needs to be taken into account in formulating policy. And if hepatitis C is to be eliminated as a global priority, clearly the issue of price needs to be addressed. We have reason to believe, as I mentioned before, that this is now in the works.
The idea is to match people as closely possible on their observable characteristics, like propensity score or other matching, and then make them near on those characteristics very far apart on the instrumental variable. I'm a 32-year-old Indian man. You find another 32-year-old Indian man in another state, and we're very far apart in terms of whether or not our food stamp program has efficient enrollment. Near on observed, far on our instrument. The idea is that it actually makes the weak instruments quite a bit stronger.
Questions, some intuitive questions about what is happening to the distribution of child mortality within countries. So the overall child mortality in low-income countries has been declining, but that can be consistent either with a convergent picture between the wealthier and poor, or with a divergence. If one looks at the big data sets, such as the global burden of disease, you can't really tell what is happening to child mortality based on wealth.
So a lot of numbers. Jim was correct to suggest that I focus on some. So for the world, the forecast by 2030 on demand is 7.3 million healthcare workers. The need-based analysis using the ILO, which is the number of healthcare workers you need for universal coverage, is 5 million. And then WHO criteria. So these are different need-based numbers.
We have known for decades and decades and decades how to very effectively treat depression and anxiety, and we can do it through many different ways and in very low cost ways. And yet the burden of mental disorders continues to increase. So what we really need are, what this tells us is that we must be working harder in implementation science, making the economic arguments that will be persuasive, changing policymakers' minds, and economic arguments are critical to that.
So we have done the econometric modeling to show that if we just use the current data, raise the one renminbi, which is about 15 cents per pack. The raise tax would be increased from 45% to 51%. And government revenue would be increased by 85.4 billion. We obviously, our audience is the government, so we have to make sure that the leaders of governments know that it's going to be win-win policy.
And these findings that you get out of this more torturous econometrics actually just reinforce the graphical intuition in that you don't see large and any significant decline really in infant mortality or child mortality. That's including if you do quantile regression, but you do see gains in literacy. So if your VPD, your vaccine preventable illness prevalence, was higher by 5 per thousand, that is implied a 10% increase in percentage point increase in literacy, and the declines in disability are about 1 percentage point decline.
So we ran a randomized trial. We had two messages, our very best germs and health message and our very best disgust and shame shit message. Across our study arms, we did not get increased use of the chlorine, or some people boil, and we didn't see more safe water in any sustained way.
So the bottom line is these small amounts of compensation were very effective in promoting uptake within a 2-month period, certainly compared to the control and the smaller compensation amount. If you think about it from the standpoint of cost effectiveness, we have modeling results that suggest 5 to 10, every 5 to 15 circumcisions can prevent 1 HIV infection. So if you're talking about spending an additional $12 to compensate men, or an additional $15, given the number of circumcisions we would generate, that's certainly highly cost effective.
So the take-home message is that the behavioral economic works may work more multiple disease. This is an intervention package that should be considered to reach the Millennium Goals and also the grant coverage. However, the effect size is very low, and the maximal effect was about 60% in vaccination. We observed that.
Our main areas of focus are health economic, decision sciences, development economics, and health law now. We have recently, over the past 2 years, recruited 2 of the very best health law scholars in the world to Stanford. And so that's a new area for us that we're incredibly excited about. And some of it does have to do with international health. A lot of it's domestic. And so those really are the main areas. And again, I just want to give my thanks to Jim and everyone up here and tell you how delighted we are to be a part of this.
Up until now, officially speaking, GHECON is just UCSF with many supportive friends outside. Doug actually is the chair of our external advisory board. And with this meeting, which we're co-hosting, as you all know, we hope that's the beginning of extending GHECON to being a multi-institutional enterprise.
Well, we have a very large and distinguished economics department. Half of the Nobel Prizes the last 10 years have come out of that department. So it's pretty high level, and people do dabble, but they're not totally in the field, but there is some really high level classy work going on there.